I'm going to do over the next 30 minutes or so is just bring together some of the things that you've already heard this morning and really refresh some of the things you've heard in the past in talking about the crashing ventilated patient. So we started this morning really getting the patient successfully intubated and then setting the ventilator right, really paying attention to tidal volume, respiratory rate, the FiO2, appropriately intubating, appropriately sedating the person and providing them with adequate analgesia, and then depending on the type of patient, using alternative modes of mechanical ventilation. And something that our residents, our faculty see all too common here in our ED is really PRVC, and those were some outstanding pearls that Mark conveyed to us in the last lecture. Now, to get things started, I do not have any financial disclosures, but what I would say is I love this quote. It is from Yoda, so those of you that are Star Wars aficionados, knowing, thanks to Dr. Who's reminder yesterday, that yesterday was in fact National Kiss a Wookiee Day. I was unable to find any Wookiees around in the environment, but leveraging Star Wars, I think this is an outstanding quote. The greatest teacher failure is. And I will tell you that several Novembers ago, as I drove home from a morning ED shift, I truly wondered whether my failures that morning would have potentially cost Miss G her life. Now, Mrs. G was a lovely 58-year-old female. She had a history of CHF, COPD, for which she had had 2 prior intubations, as well as HIV with a fairly robust CD4 count, who was brought into our emergency department with shortness of breath, vomiting, and near syncope. And her history of present illness for about 7 to 10 days prior to her ED presentation. She had developed some upper respiratory symptoms. This was pre-COVID, had a productive cough, subjective fever. She had gone to see her ID physician, who treated her empirically for community-acquired pneumonia with Augmentin. And for the first 24 to 48 hours, she got a little bit better, but then really failed to improve and started to worsen the days leading up to her presentation. And on that morning, she was able to successfully make it to her methadone maintenance therapy, took her dose, but then as she left the methadone clinic, she started feeling abrupt onset of shortness of breath. She had several coughing episodes, some post-tussive emesis, threw up while waiting for the bus to take her home, and bystanders witnessed her slumping to the ground without signs of head trauma, but really with a near syncopal or probably a syncopal event. EMS was activated, and when they got on scene to Mrs. G, they noted her to be markedly hypoxemic, saturations in the low 70s, and tachypnic, breathing in the mid to upper 20s. They put her on about 6 liters of nasal cannula and quickly brought her into our emergency department, where she arrived persistently hypoxemic. Saturations at best were about 86-87% on that 6 liters of nasal cannula. She was tachypnic, using accessory muscles, and had diffuse bronchi on her pulmonary exam. We were able to get a quick portable chest X-ray which demonstrated this finding. So certainly no cause for confusion as to why she may be hypoxemic. Now, very quickly, we escalated her from nasal cannula using high-flow nasal cannula, or converted her over to high-flow nasal cannula with a fairly moderate setting. Went down our sepsis pathway, so she got broad-spectrum antibiotics, got IV fluids. But then over the course of the next several hours, when we had no available IMC and subsequently ICU bed to admit her to, she developed increasing oxygen requirements. That high-flow nasal cannula, we were titrating up higher and higher. And when her nurse came out and said she's dropping her pressures, going back to the bedside, seeing a blood pressure of 86/45, we knew it was time to intubate Ms. G. So we put her on 100% non-rebreather to try and pre-oxygenate her, increase that safe apnea time. Started her on a little bit of IV fluids, drew up 30 milligrams of etomidate along with 100 milligrams of rocuronium, and proceeded to perform rapid sequence intubation. And unfortunately, within 30 to 60 seconds, her saturations were plummeting. We had to abort the first attempt, use bag valve mask ventilation to bring her sats back up, and then thankfully on the 3rd attempt, using a bougie, was able to get her successfully intubated, switched her over to the mechanical ventilator, but within 5 minutes of initiating mechanical ventilation, Mrs. G lost her pulse and went into a peri-intubation cardiac arrest. So when we talk about the crashing ventilated patient, I like to break it down into 3 different scenarios. Exactly Mrs. G's case of that peri-intubation cardiac arrest for when you start ventilation within the first few minutes and patients crash. When you've got patients then on the ventilator, perhaps they're boarding in the ED and they rapidly decompensate, become hemodynamically stable, what are just a few pearls and a relatively easy mnemonic to remember to think about what the causes are and then what to do in that hemodynamically unstable vented patient. And then when you've got that ICU boarder in your ED that is continuing to slowly worsen and deteriorate, what is that stepwise approach to thinking about what could be causing their deterioration and what are the things that we can do to ultimately reverse that decompensation or deterioration and improve their morbidity and mortality. So in terms of poll everywhere, just a quick question here. Which of the following is the strongest risk factor for peri-intubation cardiac arrest? Is that pre-intubation hypertension, pre-intubation hypoxemia, post-intubation shock index, or post-intubation tachycardia? What does the literature say is the strongest risk factor for a peri-intubation cardiac arrest? I'll give you a few moments to respond. All right, so some folks thinking about the post-intubation shock index. All right, well, let's get into that first scenario. The intubated patient who you've just placed on mechanical ventilation within the first few minutes of completing RSI, and they have a peri-intubation cardiac arrest. Let's kind of put a little bit of numbers around that. How frequently is it occurring in our critically ill patients? This is a paper that we reviewed perhaps in prior critical care symposium and literature updates by De Jong and colleagues in critical care medicine. Now, they took a look at a retrospective analysis with 3 objectives. How common was peri-intubation cardiac arrest in the critically ill? Was it associated with increases in morbidity and mortality? And I think, most importantly, what were the risk factors that identified patients may have a peri-intubation cardiac arrest? Well, they identified 6 trials with just slightly over 1,800 patients. And as you can see here, the incidence of peri-intubation cardiac arrest was right around that 3% of intubations in critically ill patients. Now, most importantly, my takeaway from this particular paper is the authors and investigators were able to identify 5 factors or risk factors that predicted or were associated with patients sustaining a peri-intubation cardiac arrest. Hypoxemia prior to intubation makes sense. Pre-intubation hypotension, the absence of any attempt at pre-oxygenation, obesity, and then age over 75. And of those 5, the 2 strongest predictors were in fact hypoxemia prior to intubation and hypotension prior to intubation. Well, this study was of adults, but what about those of you that care for and unfortunately then need to intubate critically ill pediatric emergency department patients? This was published within the last year in Pediatric Emergency Care. And this was now admittedly not a retrospective or a multi-center cohort. This was out of a single center ED that primarily took care of pediatric patients. And they wanted to identify the same objective. What were the risk factors in the pediatric ED population that predicted a peri-intubation cardiac arrest? So as you can see, they found a little over 500 patients and around the same number, about 3 to 4 to 5%, sustained a peri-intubation cardiac arrest. And usually, they had the onset of that cardiac arrest within the first few minutes of getting them intubated and then transitioning them to mechanical ventilation. And very similar to the De Jong paper looking at adults, hypoxemia prior to endotracheal intubation, hypotension prior to intubation, and for pediatrics, delayed capillary refill time and failed first pass success were those risk factors in the pediatric population that predicted peri-intubation cardiac arrest. And the 2 strongest, similar theme to adults, hypoxemia prior to endotracheal intubation and hypotension prior to intubation. Now, there's a few more recent papers that we'll just touch on. This was just published in the last few months in Resuscitation. This was a secondary analysis of NEAR. Recall that it is the National Emergency Airway Register to take a look at what was the prevalence of peri-intubation cardiac arrest in emergency department critically ill patients that needed emergency airway management. So they included patients over the age of 14, whereby the intubating provider did note in their documentation that the patient had a peri-intubation cardiac arrest. And you can see just shy of 16,000 encounters, a little bit lower on the incidence of peri-intubation cardiac arrest of about 1%. But what these authors reported is no surprise. Those patients, our patients that sustain a peri-intubation cardiac arrest, have a significantly higher ED mortality than those that don't have a peri-intubation cardiac arrest. And more importantly, those risk factors, a pre-intubation shock index and pre-intubation hypoxemia, were the two strongest predictors of peri-intubation cardiac arrest. So very similar themes across studies of hypoxemia heading into RSI strongly predicts patients who may sustain a peri-intubation cardiac arrest, and hypotension or an elevated shock index pre-intubation identifies patients who may code shortly after securing the tube and initiating mechanical ventilation. And lastly, this was the Intube study that was just published in JAMA. Some of you have seen this in various social media outlets talked about. This was an international prospective study, 197 centers across 29 countries to really assess not only the incidence, but evaluate risk factors for major peri-intubation events in critically ill patients. You can see they included adult patients who were intubated either in the ED, on the floor, or in the ICU, and they wanted to determine what was the incidence of major events. So this was a composite outcome of severe hypoxemia, SATs dropping below 80%, cardiac arrest, or cardiovascular instability. Just shy of 3,000 patients in the Intube study, most of which were intubated for respiratory failure, and almost half, so 45%, had at least one of those major adverse events in the peri-intubation period. Now, the majority were cardiovascular instability, so dropping their pressure post-intubation. But you can see here a similar theme in terms of numbers of peri-intubation cardiac arrest, around that 3%. Now, similar to the study we just reviewed from resuscitation, with an increase in ED mortality for peri-intubation cardiac arrest, these authors reported not only an increase in ICU mortality, but patients who sustained a peri-intubation cardiac arrest had a markedly increased 28-day mortality. So key pearl or take-home point number one in that first scenario of the crashing ventilated patient, those that sustain a peri-intubation cardiac arrest, it occurs around 3 to 5% of the time. And of all of the intubations we perform across the US and across the world, this tends to be a fairly common occurrence. And I bet as we say this now, many of you can think back to those recent cases of peri-intubation cardiovascular collapse or cardiac arrest. And those main key risk factors that identify patients that may sustain a peri-intubation cardiac arrest: pre-intubation hypoxemia, typically characterized by saturations less than 90%, pre-intubation hypotension, depending on the study, that could be a systolic blood pressure less than 100 or less than 90, and an elevated pre-intubation shock index. And when patients sustain peri-intubation cardiac arrest, absolutely it's associated with increases in ED, ICU, hospital, and 28-day mortality. And in the case of Mrs. G, she absolutely had several of those. Certainly pre-intubation hypoxemia and pre-intubation hypotension with an elevated pre-intubation shock index. All three risk factors that were saying she was at very high risk of sustaining a peri-intubation cardiac arrest that November morning when she presented to us. Now, why do patients sustain that peri-intubation cardiac arrest? Likely multifactorial. So in general, many critically ill patients are hypovolemic. Their endogenous catecholamines are maxed out, and they have essentially converted that unstressed venous volume to stressed venous volume, and thereby attempting to improve venous return and sustain cardiac output. We then administer RSI medications, which takes away some of that catecholamine effect, thereby converting the stressed venous volume back to unstressed volume. Patients become hypotensive, decreased venous return. We convert them from negative pressure ventilation over to positive pressure ventilation, thereby also decreasing venous return and likely causing cardiovascular collapse. So you heard this from Dr. Martinelli a few lectures ago, and you've heard this by airway gurus such as Dr. Ken Butler, Dr. Rich Levitan. We are going to be maximizing those patients' physiology before performing intubation and subsequently placing them on mechanical ventilation. We're going to be doing that resuscitate before we intubate. And we can do a few things. Dr. Martinelli talked about some IV fluids, some vasopressors. I would also submit choosing wisely with respect to RSI medications. And I think from heading into intubation, we know pre-intubation hypotension is a risk factor for peri-intubation cardiovascular collapse, and administering IV fluids is very reasonable for those patients, but understand it may not completely prevent cardiovascular collapse or that peri-intubation cardiac arrest. Recall this was a paper we reviewed from about a year and a half ago. This was the PREPARE trial. This was a pragmatic randomized trial done in 8 EDs and 8 ICUs and 1 ED to say, does giving fluids during that peri-RSI time frame actually prevent cardiovascular collapse? So in essence, they took adults undergoing endotracheal intubation and randomized them to get fluids from the time of induction through laryngoscopy. Now, admittedly, that was only a 500 milliliter bolus of an isotonic crystalloid. Or patients were randomized to get no IV fluids during the time of induction through at least 2 minutes following successful laryngoscopy. And they wanted to know a composite outcome. Did patients become hypotensive? Did they need pressor initiation or a titration up of existing pressors? Or, as we're talking about here, did they sustain a peri-intubation cardiac arrest within an hour of being intubated, or did they actually die within that hour following intubation? Well, as you can see, they only included 337 of their planned 500 patients because at the end of the day, there was no difference in that composite outcome of cardiovascular instability, peri-intubation cardiac arrest, or death between those that were randomized to IV fluids versus no IV fluids during that RSI and early laryngoscopy period. Now, I'm definitely not saying don't administer IV fluids. I think for many, very reasonable to start off with IV fluids to correct that hypovolemic state and correct that peri-intubation hypotension. Just be aware that simply IV fluids alone may not prevent cardiovascular collapse and peri-intubation arrest in that high-risk patient. So, in line with what Dr. Martinelli was saying, have your pressors handy. Over the last many, many years, bolus dose or push dose pressors have become fairly common in emergency medicine along with critical care. It's been talked about for probably a decade now at national conferences, regional conferences, blog posts. But in reality, there's actually very little information, published literature, with respect to bolus dose pressors. The two most recent with respect to emergency medicine were about a year and a half ago, 2 single-center studies. This first one was in the American Journal of Emergency Medicine. This was a retrospective cohort at a single academic center in Canada, basically saying, well, what has their experience been with the use, efficacy, and adverse events with bolus dose or push dose pressors. So they included adult patients that got either phenylephrine or ephedrine as a bolus dose pressor. And these authors defined adverse events as the following. Patients who got a bolus dose or push dose pressor had a marked increase in systolic blood pressure well above 200, or a doubling of their systolic pressure. Changes in heart rate, so a significant increase or a decrease in heart rate. Did it cause any dysrhythmias or any signs of ischemia? And they also classified medication errors. So these were patients, they had an existing push dose pressor protocol. Did the patient get more of phenylephrine or ephedrine that their protocol called for? Did they get a push dose pressor and they actually weren't hypotensive? Or did they get a push dose pressor and were already receiving a continuous infusion? And just shy of 160 push dose pressor events, most commonly given for post-intubation hypotension. And you can see that more than 1 out of 10, in fact, 11% had one of those adverse events. And over 11% had a medication error in this single-centered experience with push dose pressors. Now, very soon after that American Journal of Emergency Medicine publication, there was one in the Journal of Medical Toxicology, also a single center. This was a U.S. academic ED to quantify their adverse events associated with bolus dose pressors, specifically in the emergency department. So they looked at all of their ED patients who got a push dose pressor of either epi or phenylephrine, and they classified adverse hemodynamic events as marked tachycardia or bradycardia, significant hypertension, or the induction of VTAC in those that got a bolus dose or push dose pressor. They also classified human error. In other words, patients were given the wrong dose, and also included documentation error as components of this human error as to whether they were able to see that a push dose pressor was given but never documented, or problems regarding the timing and documentation of the outcome of a bolus dose pressor. Here you can see that almost 40% of patients in this single center academic ED had an adverse hemodynamic event, significant tachycardia, bradycardia, significant hypertension, or the development of VTAC, 50% of which occurred with push dose epinephrine. And you can see here 1 in 5 had one of those human errors. Now, admittedly, the majority of those were documentation errors, but in all 7 of the dosing errors, those were all excessive doses of push dose pressor. So I'm definitely not saying that for many of you, from a resource standpoint and being able to actually get a continuous vasopressor infusion, you may need to utilize a bolus dose or push dose pressor. But understand the literature, at least pertaining to emergency medicine, on the use of this practice does quantify a significant adverse drug event and medication error event with this practice. So identifying patients that are at high risk for peri-intubation cardiovascular collapse with those risk factors, starting with IV fluids, understanding that that may not prevent cardiovascular collapse, and really in those high-risk individuals, leaning on your ED pharmacist and working collaboratively with them early to get a continuous infusion of vasopressors to go during that RSI period, I feel is a much safer practice than the intermittent use of bolus dose or push dose pressors. And lastly, just thinking about the selection of RSI medications, especially in critically ill patients and hypotensive patients, we reach and are reaching with increasing frequency for ketamine. So I just want to throw this article up there that was published 7 months ago in Academic Emergency Medicine, alongside another article looking at ketamine and etomidate in sepsis that has generated a lot of discussion, a lot of controversy, especially in the social media realm. Now, this was overall, once again, a secondary analysis of NEAR, that National Emergency Airway Registry data, to compare patients that received either ketamine or etomidate in the emergency department and what was the association with post-intubation hypotension. So they included adult patients over the age of 14 that got intubated. Now, importantly, these weren't crashing patients. These were normotensive patients who either got ketamine or etomidate. They did not have critically ill patients, so pre-intubation hypotension patients, when we're probably more likely to reach for ketamine. And overall, in this cohort, they wanted to determine what was the incidence of peri-intubation hypotension or systolic pressure less than 100. So you can see a little over 6,800 patients, just shy of 740 got ketamine compared to etomidate. And in full disclosure, there was some differences in patients who received ketamine as an RSI sedative. They were more likely to be trauma patients or those that had sepsis, more likely to get video laryngoscopy rather than direct, and then also more likely to have, as judged by the intubator, a difficult airway. So there is likely selection bias in those that got ketamine. But as you can see here, at the end of the day, actually there was a higher incidence of peri-intubation hypotension in those that got ketamine compared to those that received etomidate. And in terms of treatment for that peri-intubation hypotension, more frequently patients needed treatment for peri-intubation hypotension who received ketamine as their induction sedative than those who received etomidate as their induction sedative. Importantly, I am definitely not saying put ketamine back on the shelf and don't use it as your sedative in RSI. What I would suggest to you, and hopefully our UM-EM airway guru, Dr. Butler, would agree, is that any sedative can in fact cause myocardial depression and result in peri-intubation hypotension. Yes, it can even occur in ketamine. And so that's why you'll hear a lot of folks say in these critically ill patients and those that have peri-intubation hypotension, perhaps a pre-intubation high shock index, really consider decreasing or halving the dose of your sedative and potentially doubling the dose of your paralytic, still to give you optimal intubating conditions, but hopefully prevent that peri-intubation cardiac arrest that Mrs. G suffered shortly after initiating mechanical ventilation for her that November morning. So in terms of that first scenario, the peri-intubation cardiac arrest, key pearls, risk factors for patients who are likely or at high risk of having a peri-intubation cardiac arrest. The strongest is pre-intubation hypoxemia, so doing everything we can in the pre-RSI period to maximize pre-oxygenation attempt. And then pre-intubation hypotension or pre-intubation elevated shock index. So maximizing their physiology, certainly starting with IV fluids, and in high-risk individuals, getting your vasopressor infusion, not only primed and at the ready at the bedside, but for many actually initiating that infusion as you head into RSI, and then choosing wisely with respect to the selection of your sedative for RSI, and understand that even ketamine can cause hypotension as it does have myocardial depressant effects. Let's transition now to the second category, so the hemodynamically unstable. And let me present to you the case of Mr. AF, lovely 79-year-old gentleman who has a history of COPD and also 2 prior intubations, the last of which was about a year ago, who was brought to our emergency department by Baltimore City EMS for acute respiratory distress. And Mr. F, about 2 hours prior to activating EMS, had the relatively abrupt onset of shortness of breath. And when it progressed and wasn't improving, he called 911. Upon arrival at Baltimore City EMS, they found him tripoding, accessory muscle use with very little respiratory or tidal volume. They stated on auscultation, diffuse wheezing. So they initiated CPAP on him, provided him with bronchodilator therapy, gave him IM Decadron or dexamethasone, and transported him to our emergency department, where he still arrived markedly tachypnic, diaphoretic. We transitioned him from pre-hospital CPAP to our non-invasive ventilation, continued that, delivered continuous bronchodilator therapy, gave him magnesium. But after about 15 to 20 minutes, it was clear that Mr. F was worsening, and he did need to be intubated for an acute COPD exacerbation and initiated on mechanical ventilation. He was safely intubated on first pass success, did not sustain a peri-intubation cardiac arrest, and was placed on assist control, volume cycled, as you heard from Dr. Allison this morning, with a tidal volume of 450, getting that right, a respiratory rate of 24, a PEEP of 5, and an FiO2 initially of 100%. He was initiated on appropriate post-intubation sedation and analgesia based upon Dr. Martinelli's recommendations. We then stepped out of the room to start looking for an ICU bed, and to no surprise, there was no room at the inn in our medical ICU. However, there was a bed at one of our affiliated institutions in the intensive care unit. So we started making those phone calls to arrange for his transfer to their ICU, which is just a few blocks up the street from the University of Maryland Medical Center. And about 35 minutes following his intubation, his nurse, Faith, came into the provider area to say, he's dropping his pressure. In fact, it was 65/35, so we quickly returned to Mr. F's bedside to try and troubleshoot and figure out why he had become abruptly hemodynamically unstable, having recently been placed on mechanical ventilation. So with that, let's jump back into a poll everywhere question for you. Which of the following patients is at greatest risk for developing auto-PEEP? Is it a 56-year-old female intubated for ARDS secondary to sepsis who you initiate ventilation using a volume-targeted mode? A 68-year-old male who is intubated for an acute COPD exacerbation who you ventilate using a pressure control mode or pressure-targeted mode? Or a 38-year-old male who is intubated for severe asthma who you ventilate using a volume-targeted mode? Which one of these three is at high risk for developing auto-PEEP and subsequently becoming hemodynamically unstable while on the ventilator? Thank you to all who are responding. It's great to see the interaction. All right, so when we move into this second big category of patients who you've intubated, you've set the ventilator initially, you're able to then see a few other patients, and then they abruptly decompensate, deteriorate, and develop hemodynamic instability on the ventilator. What do we want to think about? And this is probably, outside of the peri-intubation cardiac arrest, one of the most stressful settings where the ventilator is alarming. You have the eerie signal of the pulse oximetry. The heart rate may be decreasing or markedly elevated. Pressure's dropping. Alarms are going off. Everybody's rushing into the room. How can you calmly approach the patient and figure out not only what's going on that's resulting in their hemodynamic instability, but what things can you do immediately to help reverse and stabilize that patient and resuscitate them? And this is something that many of you have heard, using a very easy mnemonic, the DOPES mnemonic. And the DOPES mnemonic helps you walk through the etiology of the hemodynamic decompensation in that patient. So what are we talking about with respect to DOPES? Thinking about, has the ET tube or the endotracheal cuff become displaced? Has the ET tube become obstructed? So is it a patient with marked secretions, perhaps multifocal pneumonia, and the ET tube is now clogged with secretions? Is the ET tube kinked somewhere in the oropharynx? Or, thinking back to Dr. Martinelli's discussion, is the patient inadequately sedated and they're actually biting the tube, causing obstruction? Is this a patient who we have ventilated on very high tidal volumes? Perhaps they have auto-PEEP and we've induced a tension pneumothorax with mechanical ventilation. Is there an equipment failure? So something has happened with the ventilator where the circuit has become disconnected, or we have equipment failure with the ventilator or any of the tubing all the way up to the ET tube. Or, as what was occurring in Mr. F that day, is he at risk, or is the patient at risk for progressive auto-PEEP or stacked breaths, and we subsequently need to resuscitate and eliminate auto-PEEP? And of those two, when you've got that crashing or hemodynamically unstable patient on the ventilator, really be thinking about the development of a tension pneumothorax or severe auto-PEEP. And the patients at highest risk for severe auto-PEEP are those with obstructive airway disease that are ventilated using volume-targeted modes. And that is exactly what occurred with Mr. F that morning. Recall his ventilatory settings were assist controller volume cycled, tidal volume 450, and because he came into Kipnick, he had a respiratory rate set of 24 with 5 of PEEP and FiO2 of 100%. And within the 30 minutes after initiating mechanical ventilation, he had developed severe auto-PEEP, resulting in cardiovascular collapse. So when we're at the bedside, alarms are going off, folks are frantic, trying to resuscitate and save the life of that dying ventilated patient, and you're thinking, what's the cause using your DOPES mnemonic? Well, what do we do now? We can simply think of the DOTS mnemonic as a way to resuscitate, troubleshoot what's going on, and hopefully save the life of that dying patient. And so thinking about DOPES, and now moving on to dots, really the first step is to disconnect the patient from the ventilator, remove that from the equation as to what may be occurring, and not only disconnect, but consider in patients at risk for severe autopeep, decompress the chest. So in some cases, you'll see pressing down on the chest, and you'll hear all the expiration of that air through the endotracheal tube. So disconnect them from the ventilator, and then ventilate them using bag valve mask ventilation. So placing them on 100% FiO2, bagging them, listen close to the ET tube to see if you hear air leak, which may indicate a problem with the endotracheal tube cuff. And then as you're bagging them, assess their compliance. Are they very easy to bag or very tough to bag, indicating perhaps conditions of increased lung compliance? Confirm your ET tube position. So one of the primary etiologies is a dislodged or displaced ET tube. So whether you perform DL, VL, or now when we've got disposable bronchoscopy devices in several of our EDs, consider doing a bronch to confirm the ET tube is in the right location. Also feeling the pilot balloon to ensure that there is no cuff leak or dysfunction with that tube. And if you do have that patient where you've disconnected, you hear that rush of air, they have hemodynamic stability return, and they are that patient who has developed autopeep, then adjusting your ventilator. And as you heard from Dr. Allison and Dr. Sutherland, providing them an increase in time for expiration is what you want to do, or modify in the patient, modify the ventilator for the patient who has developed autopeep. And then also consider doing ultrasound. So your point of care ultrasound, knowing that tension pneumothorax is one of the more common etiologies of hemodynamic collapse in the ventilated patient, looking for the absence of lung sliding. So in that second category, the key take-home message is when you have someone who abruptly decompensates, hemodynamically unstable, and on the ventilator, a high-stress situation, think about your dopes mnemonic to consider the etiology between a dislodged, obstructed tube, equipment failure, pneumothorax, and just use the DOTS mnemonic of disconnecting them, placing them on 100% FiO2, bagging them, confirming tube position, using ultrasound to exclude pneumothorax, and then adjusting the ventilator once you've gotten restoration of hemodynamic stability. And then in the final minutes here, that last category, when you've got that ED ICU boarder who is ventilated and then slowly deteriorating, slowly decompensating, what are a few other things you want to consider and a stepwise approach to determining why they're deteriorating? And this was the case of Mrs. M, a 44-year-old female with no past medical history, who had come in with about a week of upper respiratory symptoms, but over the preceding 12 to 24 hours had a marked increase in shortness of breath along with dyspnea and exertion. She came into triage with room air saturations of 77%, no prior pulmonary history, was quickly brought back to room 19 in our ED, where on auscultation, diffuse bronchi bilaterally, tachypnic and a portable chest x-ray had demonstrated multifocal pneumonia. She got entered along our sepsis pathway. She got cefepime, vancomycin. She also got azithromycin, got her IV fluid challenge, and then was placed on supplemental O2 that over the course of the next 2 to 3 hours slowly was titrating up, going from nasal cannula, converting to high flow nasal cannula, and dialing up the FiO2. And after about 5 hours of time in the ED, waiting initially for an IMC, but now an ICU bed, her O2 requirements really elevated to the max supplemental O2, and she required endotracheal intubation. She was placed on assist control, tidal volume 450, respiratory rate of 16 breaths per minute. She required initial PEEP of 12 and an FiO2 of 100%, so really maximal settings from a supplemental O2 standpoint. And she continued to board in the ED. She was receiving her IV fluids with respect to sepsis protocol, continued antibiotics, but she had a fairly long ED length of stay. And at change of shift, those saturations were now starting to decrease. Her pressures were starting to decrease. They were becoming softer and starting to trend down. And the ventilator was now, with increasing frequency, starting to alarm with higher pressures. And so with that, our last poll everywhere question. A 44-year-old female is intubated for acute hypoxemic respiratory failure secondary to pneumonia. Inspection of her flow time curve demonstrates double triggering. Which of the following steps would best alleviate this condition? Is it decreasing the respiratory rate? Would you decrease the tidal volume? Would you increase the inspiratory time, increase the FiO2, or none of the above? You're at the bedside of this patient. What would you do next? All right, is it just one lonely answer for none of the above? There we go. Give it a few minutes. So none of the above. Folks are thinking about maybe decreasing the respiratory rate, perhaps decreasing tidal volume, maybe increasing the flow time. Outstanding interactions. All right, well, let's drive home here in this last section. What is that stepwise approach to really identifying what the cause is of this patient's continued deterioration? They're not hemodynamically unstable, but certainly they're worsening. And you've got a little bit of time in this scenario, unlike the peri-intubation cardiac arrest and the abrupt hemodynamically unstable vented patient. You have time to really take a focus history. So why did they get intubated? Were they a difficult intubation? Did they have post-intubation hypotension? Are key questions, but what I would say from a Pearl standpoint, look at the last set of ventilator settings. Did they have recent ventilator adjustments? And equally important, was there any recent procedures performed before this patient started to deteriorate? Central line placed, any other procedures that can clue you in as to why this patient may be decompensating. After that focus history, you've then got time to do a focused exam. So how are they clinically looking? Be sure to check the depth of the ET tube and compare that to what was listed at the time that they were intubated to determine if the ET tube has become dislodged or migrated. Feeling the pilot balloon, listening for an air leak with each respiration can give you enormous clues. And considering, once again, a partially obstructed ET tube past a suction catheter, listening to both sides of the chest, and also looking at the ventilator circuit to see if you're seeing any oscillations of water that could be affecting their overall ventilation. Take a look at their gas exchange. So you've done a focus history, recent vent changes, any recent procedures, a focused exam, and now look at their gas exchange. You're looking at pulse oximetry, but hopefully many of you at this point in time have end-tidal or waveform capnography from an end-tidal CO2 standpoint to look at their ventilation. And if you're able to look at the trend in that capnography waveform, and if it is slowly decreasing, that gives you enormous information to say, does this patient have an obstructed ET tube? Is the tube disconnected somewhere along the ventilator circuit? Is there a cuff malfunction and is there an air leak? Or is the patient becoming hypotensive? Enormous information in looking at gas exchange. And then your respiratory mechanics. You heard Dr. Allison start us off today with plateau pressure. Well, in terms of assessing their respiratory mechanics, really identifying and measuring their peak and their plateau pressure. Now, with peak pressure, you're going to see this regularly on the ventilator. It's going to be alarming every time. It usually exceeds 40 or 50, whatever the threshold is set by your respiratory therapist. And in general, peak pressure is a function of the tidal volume you're giving, the resistance of the airways, and the compliance of the lungs. Where we want to be consistent in our ventilated ED patient is measuring that plateau pressure. We do it with an end inspiratory pause, and that number you get, while it's a gross oversimplification, generally reflects the compliance of the lungs, and our target is less than 30. So when you have that slowly deteriorating patient, focus history, focused exam, looking at end-tidal CO2, and then looking at the difference between peak and plateau pressure. Here you will see this on the ventilator waveform in your peak inspiratory pressure and your plateau pressure. And when you have an increase in peak, but a stable plateau, so there's a delta, that clues you into that this is more likely to be a resistance issue. So in the asthmatic as worsening bronchospasm. Or it's an obstructed ET tube, a dislodged tube, or once again, inadequate sedation and the patient is awake and biting the ET tube. Now that's in contrast when you have an elevation in both peak and plateau, and that is usually worsening compliance and worsening of the patient's underlying condition. That may be progressive pulmonary edema. They may, in fact, have developed a pneumothorax. In the setting of sepsis, worsening ARDS. And in this patient, Mrs. M, who had continued to board in the emergency department and continued to receive large volumes of IV fluid. In fact, other conditions, other extra pulmonary conditions such as abdominal compartment syndrome, which she was developing during the course of her ED stay, that will cause a rise in both peak and plateau pressure. And really, lastly, taking a look at those ventilator waveforms, Dr. Sutherland had an outstanding example of PRVC waveforms. Really, you're looking at two, your flow time and your pressure time curve. And your flow time curve can give you a hint as to whether the patient's at risk or developing auto-PEEP. You can see here in the bottom flow time graph where the expiration does not return to zero or baseline before the initiation of the next breath. That is a patient that is developing and will continue to develop elevated levels of auto-PEEP. That is the flow time graph that you're looking for to detect auto-PEEP in patients who need a lengthening of their I to E ratio. Now, in terms of double triggering, one of the questions we led off, in essence, the patient is continuing to inspire. They want to take a longer tidal volume breath. And so without exhalation, the ventilator is triggering another breath. And for double triggering, that almost air hunger type of state, really increasing the inspiratory flow time or increasing the tidal volume will alleviate or should alleviate double triggering. And lastly, from a pressure time standpoint, you can see here in the upper curve with that flow starvation, the air hunger, patients are wanting to draw in a deeper breath. So there is a negative deflection on that pressure time curve. And very similarly to the double triggering, increasing the inspiratory flow time will alleviate that air hunger or flow starvation in this particular patient. You've then done doing point of care ultrasound, and we'll defer to Dr. Martinelli's lecture on really appropriate analgesia and sedation to determine if that may be the etiology of that slowly deteriorating vented patient. So with that, what are the take-home pearls? What would I like you to take home when you're encountering that next crashing ventilated patient? Well, those three scenarios, the peri-intubation cardiac arrest when you've just started mechanical ventilation, the patient who you ventilated and suddenly becomes unstable versus the ventilated patient who is slowly declining. For that peri-intubation cardiac arrest, the greatest risk factors are pre-intubation hypoxemia, pre-intubation hypotension, and an elevated pre-intubation shock index. Use your fluids, administer IV fluids, especially when you need to resuscitate the cardiovascular system, but know that that may, in and of itself alone, not prevent cardiovascular collapse. Be mindful that there really still is very little literature in EM on the use of bolus dose pressors, and what is out there does demonstrate a fairly high adverse event and medication error rate, and really strongly considering a continuous infusion of vasopressors to maximize the patient's physiology prior to performing RSI, and really thinking about dosing of your RSI medications. And even ketamine, though we love to use it, can still result in hypotension in some patients. So be mindful of that and consider reducing your dose of sedative and increasing your dose of paralytic. When you've got that crashing patient who you've had ventilated and they suddenly become unstable, think about a dislodged tube, an obstructed ET tube, the onset of tension pneumothorax, something with an equipment standpoint in the ventilator has malfunction, or they're that patient who has obstructive lung pathology and they've developed severe auto-PEEP. Disconnect them from the ventilator, ventilate them using bag valve mask with 100% FiO2. Pass a suction catheter, confirm that the ET tube is in the right location and functioning properly. Modify the ventilator for those that do have auto PEEP when you've alleviated that, and then perform that bedside ultrasound to exclude pneumothorax. And then when you've got the slowly deteriorating patient, that focus history, what were the recent ventilator changes, any recent procedures, that focused exam, use end-tidal CO2 capnography to your advantage to provide you with valuable information on their ventilation. Look at both the peak and plateau pressure. Is there an elevated peak? Normal plateau indicative of a resistance issue versus a rise in both peak and plateau pressure that would suggest more of a compliance problem. Look at your waveforms for, say, air hunger, double triggering, auto PEEP. Perform that point-of-care ultrasound and then ensure those patients have adequate analgesia and sedation. And with that, I can't thank you enough for your attention. Let me turn things back to Dr. Chan to see if there are any questions from those of you before we take a 5-minute break and our last discussion this morning with Dr. Hu on extubating in the emergency department.
Thanks, Dr. Winters. So 2 questions here. One was, is there a certain mode or breath type that you would choose to use in a patient with obstructive lung disease?
Great question. And is there a certain mode in obstructive lung disease? I still feel that volume control is the safest mode. It's the only mode really of mechanical ventilation where we have evidence to say that it results in an improvement in patient-centered outcomes. So with that, and ventilating the obstructive patient, I think the critical thing to know is you have to give them appropriate time to exhale. And I think the tendency, especially when these patients come in markedly tachypnic, is to match that respiratory rate, but that will quickly lead to auto PEEP. So really setting them, Dr. Allison talked about 10 to 16 breaths per minute. I'd probably go on the lower side of that, 10 breaths per minute, and in some cases maybe even 8 breaths per minute to give that adequate I to E ratio to allow them to exhale.
And the other question was, in terms of looking at your peri-intubation risk factors for cardiac arrest, the question was there any consideration about acidosis, and was there a specific pH, if there was, that would be a risk factor for arrest?
So a great question. The patient who has a severe metabolic acidosis is always a high risk for peri-intubation cardiac arrest. In my review of the literature, there's really not a single pH value as a cutoff to say below which really identifies someone at markedly high risk for crashing post-intubation and initiation of mechanical ventilation. Personally, I get a little nervous, pH less than 7.1, but that hasn't been consistently identified in the literature as strong as a risk factor as the hypoxemia, hypotension, and elevated shock index. All right, my thanks for interacting and hanging in there for our critical care symposium.